Hi everyone. Warm welcome this morning for today's presentation on prostate cancer. We are honored to have Dr. Jim Hu with us today. Dr. Hu is a urologic oncologist. He is an internationally renowned surgical innovator and health services researcher. Dr. Hu has performed over 4,000 laparoscopic, robotic, and open procedures. And in addition, Dr. Hu has published the most advances and videos of technical modifications internationally in European urology surgery in motion to improve prostate and kidney cancer surgical outcomes. So we are all delighted to have you here today so we can learn about your wealth of knowledge. So whenever you're ready, Dr. Hu, just take the floor. And if anyone has questions, please write them in the chat, or we can also wait for the end if anyone wants to ask their question aloud and make time for all of those. Thank you so much.
Great. Thanks, Allegra and your team. And I'm also grateful to Vanessa, who's on the call, for really setting up this talk with you, as well as helping me update my slides here. So let me screen share and get this into the presentation view. Okay, so are we okay with that? We can see this title slide.
Yes, perfect.
Okay, great. So this is I view this more of a discussion this morning. So I'm going to present probably for no more than 15 to 20 minutes, and we'll leave plenty of time for interaction and dialogue with the folks that have turned out nicely this morning to listen. So we're going to talk about prostate cancer in African American men, but also talk overall about kind of the big controversies, if you will, in prostate cancer diagnosis and treatment, and how I think those controversies are resolving. So we know that in the US, for example, prostate cancer is the most commonly diagnosed solid organ malignancy. And so what I mean by that is, if you think about skin cancer, whether it's melanoma, squamous cell carcinoma, basal cell carcinoma, those are very, very common as we age. But if you think about an internal organ, such as the prostate, this is the most commonly diagnosed cancer in US men. And so we know that every 13 minutes, a man is diagnosed with prostate cancer. Speaking specifically about African American men, we know that 1 in 6 African American men will be diagnosed with prostate cancer during their lifetime, and almost every 17 days, an African American man will die of prostate cancer. And so it's been controversial whether PSA, which stands for prostate-specific antigen, saves lives in terms of earlier detection. However, I'm going to show you a little bit of research that I and others have done that have really flipped the script, if you will, on whether there's a benefit to PSA screening. So we'll go through that briefly. And as we'll show in the next slide, prostate cancer survival is relatively high. And so in the US currently, there's more than 3 million men that are alive with prostate cancer. However, we do know that African American men of African descent in the US as well as in the Caribbean have the highest prostate cancer incidence in the world. So we also know epidemiologically that Black men are 2 times more likely to die from prostate cancer than white men. And they are also almost 2 times as likely to be diagnosed with prostate cancer, and when diagnosed, have more advanced stage. Okay, and some of this is due to access to health issues. For example, there was a study published a couple of years ago from the VA hospital, the Veterans Administration Hospital. And in the VA hospitals, of course, there's more equal access to healthcare. If you serve the country in some capacity in the military, you have these benefits lifelong. And it was found that in this equal access health system, that African American men, their long-term outcomes in terms of survival were no different than white men. And so there's a thinking that it comes back to nature versus nurture. That is there a genetic component that leads to more aggressive cancers being found in African American men? Or rather, is it because there's less screening due to less access to healthcare overall that leads to these poorer outcomes? And so in 2022, we know that approximately 42,000 African American men will be diagnosed with prostate cancer, and the estimated mortality this year, or death from prostate cancer, is about 6,000 men. However, as I mentioned earlier, prostate cancer, as compared to other cancers, is relatively slow growing or indolent in that the 5-year survival is about 99%, and the 10-year survival overall is about 95%. And so oftentimes this leads to the concept that we only want to look for or treat prostate cancers if a man's life expectancy is 10 years or more, okay? Because as you get older, you're more likely to die with rather than from prostate cancer. And we know from autopsy studies, that is, men who passed away and donated their bodies to science, and then there was explorations looking inside the prostate, we know that 50% of men in their 80s who passed away have prostate cancer. However, of course, very few of them died of prostate cancer or even had signs or symptoms of prostate cancer. The other important concept here is that prostate cancer is distinct from what's called benign prostatic hyperplasia, or BPH. And so BPH is simply, as a man gets older, the prostate gets bigger. And that's due to the testosterone effect. And so how that manifests or presents itself is that as we get older, we find that, for example, in the morning, it may be more difficult to start the urination. It's slower. You have to push to get it out. And so that's a different condition. That's called benign or non-cancerous enlargement. And there's a lot of medications that have been used in the last 20 years. In fact, your primary care doctor can prescribe these medications and commonly do. A urologist does not need to prescribe these medications. And if the condition persists or worsens despite medications, then there's the role of the urologist to offer surgical treatments that remove the enlarged portion of the prostate and make it easier to urinate. And so going back to prostate cancer, what are the risk factors? Well, we know that, as I hinted at earlier, as men age, the risk of prostate cancer increases. Now, going to family history as well as genetic changes, there are men diagnosed with prostate cancer at earlier ages. In fact, I've treated men who have been unfortunate in the sense that they were diagnosed with aggressive prostate cancers in their 40s. And that's when there may be genes that are passed on from father to son, and those are what we call germline mutations. And so family history can contribute to the development of prostate cancer. We talked about race, although I think this still remains somewhat controversial. But as I mentioned earlier, when there's been studies looking at equal access to the healthcare system, it seems like there's not an increased risk of prostate cancer in African American men. Alternatively, we know that, for example, in Asian countries, the prevalence, the incidence, the likelihood of finding prostate cancer is much lower. And that's thought to be perhaps due to lifestyle, which includes diet and exercise, in the sense that the body mass index or obesity is less common, for example, in Asia. There's less consumption of red meats, which hints at the diet. And in general, people walk more. There's a more active lifestyle. And so avoiding a sedentary lifestyle, or one where you don't exercise, oftentimes in the US, you're in a car, you drive around everywhere. So it's thought that those factors also contribute to an increased risk of not only prostate cancer, but other cancers. And so what can you do? Well, first, again, I spoke of the importance in terms of access to healthcare. First, again, as we'll see shortly, there's still some controversy as to the value of the PSA test. And so some internists may still be unaware that PSA has tremendous benefits. Alternatively, you don't want PSA testing if your life expectancy is less than 10 years, because then you're finding something that really isn't going to cause problems, but by finding it, you're more anxious, your quality of life is worse, you may think that you need to have it treated, and oftentimes treatment may cause incontinence, erectile dysfunction, worse quality of life, without increasing your quantity of life or your life expectancy. As we mentioned earlier, screening is largely now done through the blood test, the prostate-specific antigen. Most primary care doctors, that is family practitioners, internal medicine, internists, just add that to the battery of blood tests that you're getting drawn every year. And so that is typically how screening is performed. And again, if you will, the PSA, the public service announcement today, if you will, instead of prostate-specific antigen, is to just increase awareness, make sure that your friends, your brothers, your other family members understand this, okay? And so really, that was an introduction to prostate cancer that had a more of a focus on the epidemiology in African-American men. And in the time remaining, I'm going to speak about the epidemiology of prostate cancer overall, why it's been controversial whether or not prostate-specific antigen, the blood test, has been controversial in the US. One of the pillars of evidence we look at is what was called the prostate, lung, colorectal, ovarian trial, which was funded by the National Institute of Health, taxpayer money, and then some of the consequences from the trial, which to give away the punchline, is that the trial was really somewhat, the methodology was flawed, and therefore the results did not show a benefit to PSA screening. It led to, in 2012, the national organization, the USPSTF, or the U.S. Preventative Services Task Force, recommending against PSA screening. And then really in the last 10 years, we've seen an increase in the likelihood of prostate cancer being metastatic at diagnosis. I'm going to talk a little bit about how we can do smarter PSA screening, that is, trying not to do it so often that it causes anxiety in men, it causes men to have unnecessary biopsies, and also new ways of treating prostate cancer that still need to be explored, that may not have as many detrimental side effects, and has some appeal to men who have been diagnosed with prostate cancer. So when we look at some of the numbers, the incidence is the new cases that are diagnosed every year. And you can see how it's really increased in 2017, 2019, 2020, 2021. I think this year we're at 2022, the estimated number of new cases is 260,000. Now, some of this is, as I said, in 2012, again, the organization that lends a lot of weight to recommending screening tests like colonoscopy, even getting flu shots, they recommended against PSA screening, and we saw a drop off. And so now our research showed in 2016 that, again, the study that demonstrated PSA screening wasn't helpful was critically flawed. It's been changed back, and that's why you're seeing more PSA testing and more diagnoses of prostate cancer. However, I think also there's been an increase in the death rate. So this is the annual number of deaths due to prostate cancer, and you can see also that that's increasing. And I mentioned earlier, I'm going to show you that the likelihood of being diagnosed with metastatic prostate cancer is increasing, which means that these men missed the window of curability when they were diagnosed. Overall, the lifetime risk of diagnosis, when you include all races in the US, is 1 out of 8. I said it's 1 out of 6 in African-American men. And again, we talked about there being over 3 million Americans living currently with prostate cancer. So the controversy surrounding PSA screening is such that when you talk about a screening test, whether it's colonoscopy, whether it's if you will, a chest X-ray to look for lung cancer, or PSA, you want to really avoid finding these slow-growing cancers, and this is represented by the snail, the tortoises, because these are never going to grow quickly enough such that they may cause symptoms, or they cause deaths. So in other words, this is time. So with time, we move to the right. If you find these slow growing cancers, they're never going to cause any problems. They never reach the point where they cause symptoms, or they never reach the point where they call death, moving vertically. And so that's what we call overdiagnosis. And prostate cancer, frankly, is still overdiagnosed. And we'll talk about that a little later. But, the screening, ideally, you want to detect the bears. That is, you can see that during a man's lifetime, there's going to come a point where there's going to be both symptoms and there may also be death. And so you want to find it here before it causes symptoms, and hopefully before it spreads, such that you can get a cure. There are some cancers, for example, I mentioned these unfortunate younger men, in which by the time that we find the cancers, it's too late to find a cure. That is, they may already have symptoms, or when we do, they may not have symptoms, but once we get the pathology from the prostate biopsy and do X-ray tests, we find on X-ray that it's already spread. Okay, and so these hummingbirds, even if when we screen them, we're not going to cure these men. Looking at this graphic on the left, and again, I'm just pointing out the discrepancy between prostate cancer, which is the most commonly diagnosed, again, solid organ tumor in men, and breast cancer, which is very common in women. And so when we see that in women, mammography is used to screen for breast cancer. Okay. However, you can see that when mammography was introduced in 1980, the likelihood of metastasis at diagnosis, that is, were you decreasing the likelihood that this cancer spread when it was found? And it did not. It remained a flat line. And this just means that many breast cancers are diagnosed when it's already metastatic, the hummingbirds, okay? Whereas when PSA screening was initiated, you saw that first there was an increase in the incidence of metastatic disease. And again, that's because you found all of a sudden you were doing X-ray, you were doing biopsies and X-ray tests on men who did not have symptoms, okay? They were kind of like these bears. But then once you found the diagnosis, you did X-ray tests and it found metastases, for example, cancer in the bone that wasn't causing pain yet. So that spiked briefly, but then once you filtered out all these men that had metastatic disease, then you saw a rapid decline in the likelihood of cancer that had already spread when you diagnosed it. Okay. However, I'm going to show you that this trend started going upwards again once people stopped or decreased the usage of PSA in the US. And so also I showed, this is now on the y-axis, the number of men who die from prostate cancer annually. And you can see again, PSA started being used in the US in 1992, almost 30 years ago. You saw a drop off in the number of cancer deaths over time. And that this is in contrast to what I showed you earlier, that the number of men dying from prostate cancer is slowly creeping up again. Okay. And again, that's going to be because of the increase in the number of deaths over time. And so I mentioned that PLCO study. The takeaway, they screened about 60,000 men were randomized to getting a PSA every year. 60,000 men were supposed to not get a PSA every year, and they followed these men for 13 years to say, did PSA prevent a death with up to really, if you got PSA at 6 years, then you only had 7 years of follow-up, which frankly is relatively short period of time. All right. There was a study in Europe which did the same thing that did show a benefit to PSA screening, but really it showed at 9 years of follow-up that to prevent one prostate cancer death, you had to screen 1,400 men and treat 48 men. And so it was thought that this number to screen and this number to treat was really, really high to prevent one prostate cancer death. And so it was thought that the screening would be too burdensome. However, as I mentioned, this is at 9 years, and I'm going to show you later, if you increase follow-up or follow these men longer, then you're going to prevent more deaths. And so based on the US study that there was no benefit to screening, as I mentioned earlier, the task force recommended against PSA screening, saying that there is moderate or high certainty that PSA has no net benefit, or that the harms of overdiagnosis, as I mentioned earlier, that you'd cause men anxiety, that you would have caused men to get biopsies, which are uncomfortable, or you would cause side effects of treatment, that those things outweighed the benefits. However, as I'm going to show you later, we demonstrated that the US study was critically flawed. And then in 2018, the task force changed it from a grade D to a grade C, at least in younger men. In 2012, it was a grade D for men of all ages. And as I mentioned earlier, currently the life expectancy, or before COVID, life expectancy in the US for US men was about 78 years. Now that's been reduced to 76 because of the toll that COVID has taken. But that's why overall we say don't look for prostate cancers above the age of 70, because on average US men are not going to live past the age of 80. But what the task force did is that it said, well, for men aged 55 to 69, the decision whether to undergo PSA screening should be an individual one. Okay, meaning that it should be determined by the patient themselves whether they want PSA screening. However, I would say that, as I mentioned earlier, a lot of internists don't know the value of PSA screening, and they may not even offer this to men. As you've probably seen, when you go to the doctor's office, it's extremely challenging now to have a long conversation about, what are the upsides and downsides of PSA screening, right? And so my point here is that the primary care doctors are challenged to really explain the upsides and downsides in the very brief time that you may have with them on an annual basis. Now, the U.S. Preventative Services Task Force created this infographic to help men understand the benefits of screening. But again, I think that this is a flawed cartoon, if you will, because it says that out of 1,000 men who are offered screening, 240 get a positive PSA test, and out of that 1,000, 100, they may get a biopsy. 240 get a biopsy, 100 get a positive biopsy, and 80 of these men may choose radiation or surgery. Currently in the U.S., frankly, half of men who are diagnosed with prostate cancer have what we call low risk cancer. They grow so slowly that we don't even treat them. They do what's called active surveillance, which is where you monitor the PSA, you get a biopsy again in 3 years, and as long as it stays the lowest grade, that is a grade group 1, we know that those cancers don't spread. They're like the snails or the tortoises that I showed you on the earlier diagram, and so we don't even treat those men. Okay, so this is already a flawed cartoon, because it's saying that the treatment of prostate cancer is 80% in the US. It's 50% because half of men now don't get treated right away, at least. And it's saying that of the 80 men that get treated, about 63%, or 50 out of 80, will experience erectile dysfunction. 15 out of 80, or 21%, may experience, 19% will experience urinary incontinence. Okay, and this figure is also, I think, an overestimation, because if you're treated by a good doctor or you have one of the newer treatments that we're going to talk about, these rates of urinary incontinence and erectile dysfunction are not that high. Now, also, it says that if you're going to screen 100 men, only one man is going to benefit, okay, or avoids death from prostate cancer. And I'm going to show you how that number is really an underestimation of the benefit of screening. And this is the study where we showed that, meaning that we worked with expert biostatisticians at the Fred Hutchinson Cancer Center, which is in Seattle. And these are the top statistical modelers. And what we showed is that if you looked at 25 years from the time in the European study that a man had been given PSA screening, that number of needing to screen 1,440 men came down to 385. Okay, so then it was less burdensome, and really the number of excess diagnoses, that is, how many more men did you have to diagnose to benefit one man, was 11. Okay, and you can see that these numbers are much lower than the 16-year follow-up, which is not a projection, but the actual benefit came down from 1,440 to 570. And so you can see, again, that prostate cancer is slow growing, and that the benefit of screening and treating prostate cancer really becomes more impactful over time. Now, just keep in mind these numbers that I'm showing you, 385 at 25 years and 11. And I made that parallel, a comparison to breast cancer earlier, that the number of women who had metastatic breast cancer did not decrease after the introduction of screening mammography, okay? Now, when we look at breast cancer in the first 3 rows here, and the number needed to screen, I showed you what it is now with 25 years of follow-up, and that was 385 right here. Now, if you look at breast cancer, the number needed to screen to prevent 1 death from breast cancer, based on age, it was 1,250 for women aged 55 to 50 to 59 years, 476 for women aged 60 to 69 years, and 769 for women aged 70 to 74 years. Okay. Now, comparing it to men, again, at 9 years of follow-up in the European study, you had to screen 1,440 men to prevent 1 death from prostate cancer. At 16 years, I showed you earlier, that number came down to 570 men to prevent 1 death. And then at 25 years, it's going to be 385. And both the 570 and 385 are lower than the 1,250 for women aged 50 to 59 and the 769 for women aged 70 to 74. Now, granted, the follow-up is all 10 years, and that's what was published. But we also know that, as I showed earlier, breast cancer typically is not the snail or the tortoise. It's going to be the hummingbird or the bear. Okay, so it's going to have a more aggressive behavior than prostate cancer overall. But my point here is that when you look at the recommendation for mammography, it's actually a grade B from the U.S. Preventative Services Task Force, whereas the recommendation for PSA screening now is a grade C. Okay, so grade B means that it should be done. And why? Well, why is there that difference? Why is it that mammography, even though you have to screen more women to prevent 1 death, and that the likelihood of metastasis after diagnosis did not go down after mammography was increased, why does it get that grade B? Well, to be honest with you, men are too busy watching football on Sundays. We just aren't as proactive. We don't nag Congress, these professional societies, as much to advocate for a test that is actually more beneficial than mammography. Okay. Now, when we talk about, well, what about those men who in their 40s before it's recommended to do PSA screening? And the only reason it's currently we say to screen men from age 55 to 69 is that the only randomized control trial, that you randomize men to screening to no screening, the study was designed to enroll only men from age 55 to 69. There were not men that were aged younger that were in that study. And so because that trial, the only trial, did not include those men, we don't know the benefit in younger men, okay? But we do know that there was a study in Malmo, Sweden, where they looked at, this study was actually, the intent was to draw blood for men in 44 to 50, and then look for whether they died of a heart attack. Okay, so they followed these men for a long period of time, but because they kept track of these men so well, they also knew who were diagnosed with prostate cancer eventually, and they had the blood stored away, so then they could go back and look at the PSA. Okay, but what this is basically telling you is that if you're between age 44 and 50 and you get a PSA, and that PSA is 1 or less, then your lifetime chance of developing prostate cancer is less than 10%. And so what you can ask your primary care doctor to do in your 40s is to get a PSA. And based on that, how frequently to get PSAs in the future. Okay. And so, for example, if your PSA is 3 and you're aged 44 to 50, I mean, number one is, honestly, I would tell you should probably see a urologist, because it shouldn't be more than 2.5. But for purposes of this discussion today, a PSA of 3 age 44 to 50 means that you're approaching a 50% chance that you're going to be diagnosed with prostate cancer during your lifetime. So you can use that then to calibrate how closely you should be following your PSA. Okay. Now, one of the other things that I'm demonstrating here is how do we diagnose prostate cancer? Well, we diagnose this typically, there's an ultrasound probe in the rectum. That probe lets us visualize the prostate, and the biopsy needle goes between the rectal wall into the prostate. And many of you may have had a prostate exam. It's often joked about in movies. You have the doctor snapping on their gloves. The men have to bend over. You put the finger in the rectum because you could then feel the prostate through the rectal wall. Okay. Well, when you do a biopsy this way, of course, when a man has bowel movement, we know that stool is dirty, and you're introducing bacteria from the stool into the prostate. So the ways that we prevent infection, we have men take an antibiotic before the biopsy, but we still know that the risk of an infection is about 3%. And if you get an infection, you may end up in the hospital. You need IV antibiotics. Rarely men actually die after a biopsy because of the risk of infection. And so there's been a new way of doing a biopsy where the ultrasound probe is still in the rectum, but the needle then goes in the skin between the scrotum and the rectum. And so then you're not introducing rectal bacteria. It's kind of like drawing blood. You never need antibiotics to get a blood draw, right? You don't really get an infection after someone sticks a needle in your arm. And so that's because the alcohol prep pads or, the cleaning agents that you use on the skin kill the bacteria. And so this is a newer and potentially better way to do a biopsy that may avoid the risk of infection. I actually am leading 2 large randomized controlled trials to randomize men to a transperineal biopsy versus a transrectal biopsy to determine what the benefits are. Because if the detection of cancer is lower transperineal, then it's not really as good as the transrectal biopsy. If the other potential side effects of a biopsy, like bleeding, is higher with the transperineal biopsy, or it's so much more uncomfortable in the office, then again, there may not be greater value in the transperineal approach versus the transrectal approach. So as I mentioned earlier, we were the first to show that after men stopped PSA screening, and this is first in older men, that the risk of finding metastatic prostate cancer increased in 2012 and 2013 compared to 2011. You saw this curve increase, okay? And that's what we're seeing when I showed you overall that more men are dying from prostate cancer because we're missing the window of curability to find these cancers before they spread. It's also different now. It used to be that if you had an elevated PSA, the urologist or the internist would say, go see the urologist, and we would just do a biopsy. Now we get an MRI of the prostate first. And the nice thing about the MRI is it shows us within the prostate if there's anything abnormal. So about a third of men, if their PSA is too high or over the normal range, they don't have any suspicious areas on MRI imaging, and they then can avoid a biopsy. In the other 2/3 that do have a suspicious area, this is a more accurate way to do a biopsy because you can identify where that area is and you can hit it. So in other words, when we do a biopsy, we usually spread 12 cores throughout the prostate. And if you can think about a biopsy like a chocolate chip cookie, a cookie with 12 chocolate chips, well, the cookie dough between those chocolate chips may be where the cancer is and you can miss it. But by using MRI imaging first, you can more accurately target that area where the prostate cancer is, and therefore avoid missing those cancers as much. And so nowadays, if you get a suspicious PSA, make sure you ask your urologist to get an MRI before they do a biopsy. And this just shows you what I said earlier, that a third of men could avoid a biopsy. And when you did a biopsy, and we want to find the significant cancers, not the slow growing ones, the likelihood of finding significant cancer with an MRI targeted biopsy was 38% in men who underwent biopsy. If you did not do an MRI before, it was only 26%. So you had a 12% improvement in the likelihood of finding prostate cancer. And you found less of the tortoises and snails, the ones that you don't want to find. The likelihood of finding those very slow growing prostate cancers was 21% in those men who had an MRI first, and 40% in those who had the transrectal approach. So you don't want to find those slow-growing cancers. As I said earlier, that infographic was flawed because it said 80 out of 100 men diagnosed in the U.S. will get treated for prostate cancer. And yet, in 2016, the New York Times published an article that said that almost half of men diagnosed with prostate cancer are now treating no treatment at all, or they just monitor it with watchful waiting or active surveillance. So the over-treatment of prostate cancer has gone down significantly, again, which was a concern because it used to be that you had a PSA, you would find more of these slow-growing snails and tortoises, and then men were going to get treated for it, whereas those cancer may not cause them problems, but increase the risk of complications after surgery. There is a newer way to treat prostate cancer. Traditionally, as I mentioned, with surgery and radiation, you would treat the entire prostate. However, now there's partial gland ablation. I showed you earlier how the MRI, I'll go back to that slide, the MRI can find the prostate cancer much better and localize it. So now there's also MRI targeted treatments where we can do I actually freeze these prostate cancers here in the office. It takes 20 minutes under local anesthesia. So if you can imagine, a man can walk in, I numb up the area around the prostate just like I would with a biopsy. I stick a cryotherapy needle in it and we treat that prostate cancer, just that area, not the entire prostate. So that is a new way to treat prostate cancer that in the US is increasingly popular. We are also leading a national study to determine whether or not the cancer control for this new approach is as good as with radiation or surgery. So I'm going to wrap up there. And so what we've gone over is how the pillar of evidence that said PSA screening in the US was not beneficial, we demonstrated that it was highly flawed and contributed to overturning the US Preventative Services Task Force against PSA screening. Now it's an individual choice. So really patient education is important because I personally do not think that the primary care doctors, internists, understand the evidence for PSA screening to the degree that I've talked to you about this morning, and B, they don't really have the time, even when they do, to go over this with you in an annual health visit where they're also trying to measure your blood pressure, determine whether or not you're pre-diabetic, and go over, if you have joint pain and back pain, and try to refer you to the appropriate specialist. I talked about, really advocating for yourself to get an earlier PSA in your 40s, and then basing your frequency of PSA testing on that. We talked about how there's now an increase in prostate cancer metastasis and also deaths as a result of the decrease in PSA screening over the last decade, and how now there's new treatments that may not be as harmful in terms of side effects, but they're unproven. So we need to gather evidence in terms of whether or not these partial gland ablations or focal therapies are going to be helpful in terms of preventing spread and death from prostate cancer. So thank you for your attention. I'm going to stop screen sharing, and I'd welcome any questions from the audience.
Thank you so much, Dr. Hugh, for that great information. If anyone has any questions, feel free to raise your hand using that function, or simply speak aloud or write it in the chat.
Good morning,
Larry
Dr.
here.
Hugh.
Sorry.
Go ahead, Larry.
If I'm going to a doctor, not my GP, they send me to a neurologist, and I find that they know less about this than you do. My first thought is I'm at the wrong doctor's office. But my second thought is if we have a recording of your lecture now, it'd be great to show that to clinicians, because you're not just a fine doc, you're a research doc. The typical clinician just doesn't have the same feel for the latest data and the flow of knowledge as we get new understanding. So getting that recording out there would be really cool.
Absolutely. Well, maybe someone's recorded my presentation without our knowledge this morning, which is perfectly fine.
Yeah, I actually did record. I was going to let everyone know. I have
good.
recorded for today.
There you go. So
yeah.
you have my permission to please distribute it to whomever you want.
Hi.
Thank you.
I'm here from Diana Jones Senior Center, and one of the gentlemen has a question for you. He was asking, what if he already had a surgery for erection? Would that impact him to had any cancer, prostate cancer in the future?
Sure. So if I understand the question, it's if I've had surgery for erectile dysfunction, does that impact my risk of prostate cancer? And so first, let me just say that the prostate, what is the role of the prostate? The prostate makes about 90% of the ejaculate volume. And it basically, it has nutrients for sperm and is necessary in human reproduction. Okay. The prostate does not have, create any hormones such as testosterone. So for example, if a man has prostate cancer surgery or he has radiation that kills cells within the prostate, his libido does not go down. If he had a good surgeon, he's not going to experience erectile dysfunction. Okay. And so ED is erectile dysfunction, the likelihood of ED we know is about 50% in men aged 40 years and older in the US. And the risk factors for erectile dysfunction are hypertension, diabetes, cardiovascular disease, right? And so ED happens as we get older. It's said that ED may be may pre-stage or happen 10 years before a man experiences a heart attack, because it's oftentimes due to the buildup of cholesterol plaques in the penile artery rather than the coronary arteries. Okay. So number one is I wanted to give you the 40,000-foot view of what the prostate does, the prevalence of erectile dysfunction and the risk factors for that. Because then you can understand that surgery for erectile dysfunction has no impact on the risk for prostate cancer.
Okay, thank you so much.
Of course.
Good morning, Dr. Hu. This is Reverend Lulame. I'm at the CTSC. I'd like to find out what is being done for the primary care providers in the community so that they will be aware of what has happened in terms of evaluating the PSA and the need to evaluate it.
Of course. I mean, just like, so all physicians have, we have what's called continuing medical education credits, right? So we
Right.
all hopefully, get journals every month. We go to our national meetings. There's usually, if you're affiliated with an academic medical center, there's a teaching conference every month that you're supposed to learn new updates in terms of professional guidelines. Okay. But the challenge, Dr. Phillips, is that if the professional guideline is that, well, it's an individual choice for patients whether or not they should get a PSA test, right? I mean, that's what the current guidelines are.
That's true.
Because they looked at the evidence and they said, well, there's still a lot of downside to this. The only randomized controlled trial that was done for men aged 55 to 69. And so there, and again, I mean, not to discredit other specialists or internists, but, I'm a urologist and my expertise is treating prostate cancer, right? Like if someone comes to me and they say, look, I have, kidney stones, I need a vasectomy, I tell them, sorry, there's someone else who can do that better, right? So I focus on this. And so my perspective is going to be definitely, more narrow range and more in depth than others. And so, I think everyone is well-meaning, but, on the flip side, I see a lot of men who are aged, I saw someone recently who was 83, got a PSA test and wants to get a prostate biopsy, right? And so that's the flip side where, internists are just checking off the box every year and saying, hey, let's just get a PSA along with your kidney function, your liver function. And really that man is not benefiting from the anxiety of having an abnormal PSA in his 80s. And, if I were a misinformed urologist and just wanted to bill Medicare and do a procedure, that in an 80-year-old man, if that man gets an infection, he could end up in the hospital for 5 days. He could die from that infection, right? So So it's oftentimes, that's nothing is ever really as good as it seems, and nothing is ever really as bad as it seems. And so I think that, I think what Larry said earlier, that hopefully presentations such as this can be given to the
And go
primary
out.
doctors, but at the
Yeah.
same time, I think there needs to be increased public awareness so patients can advocate for themselves.
I think you're absolutely correct. How soon or how early, at what age do you think men should be educated, like in terms of their prostate and PSA? How early? Because I'm thinking now that maybe colleges should talk about PSAs with their students. Or do you think that's
Absolutely.
too young? Oh, okay.
Well, I think that increasing awareness is a good thing.
Mhm.
I think it's too early to do any PSA testing for a man in his 30s. I think the earliest you should consider doing it is, in your
40s.
early to mid 40s. Oftentimes the biggest source of information for these younger men is that, their fathers are diagnosed with prostate cancer. They know of the potential heritability, that is the transmission of genes, and they tell their sons about it to look for it, at an earlier age, right? But I think to your point, you're right. There needs to be more public awareness at a younger age because, like I said, if you're following, you don't. So the key here is that you only want to screen for something if the likelihood of finding cancer is going to be relatively high, right? So if you think about it, we hear about pancreatic cancer and how that's a really bad one to have, right? For example, a lot of people may know that Steve Jobs, the founder of Apple, died of pancreatic cancer, actually had a liver transplant because it had spread to the liver and was trying to, avoid death due to that. But there is no screening test in the US for pancreatic cancer. There is no blood marker. It's also so rare and uncommon that you don't want to get a abdominal CT scan on every man or woman, above a certain age, right? Because there's limited value in doing that. It'd be a huge drain on the US health system. And we already know that, it's very strapped to get a CT scan to look for a very rare cancer. And so I only go into that parallel because, I do think that every man in their 40s should at least get one PSA because I think that there's benefit for that. But I'm just trying to point out how there's a balance, right? That the burden of the disease, the epidemiology has to be such that it's relatively common for you to look for it. But, in the US, if it's the most, common cause of death, aside from, the skin cancers, right, which you can see something abnormal, then I think that shows that there's a value of that PSA test.
Yes. Thank you so very much. I
It's my
enjoyed
pleasure.
your presentation.
Thank you. It's a pleasure to have this opportunity, and thanks for having me.
Doctor, one other thing, I'm less sanguine than you are about the value of CEUs because you're so bright and you've got such a depth of understanding. I don't know if you're aware of how poor the statistical background is for many of your colleagues. I do scholarship oversight at Tufts and I do grant review here, and some really good docs, fine clinicians. But you talk about statistics and they curl up in a fetal position in terror. And epidemiology is even more subtle than general knowledge of statistics. And your arguments are statistical arguments. And you've done a wonderful job communicating it here, but you're a good communicator.
Well, thank you
the
so
typical
much.
doc doesn't get it.
Right. Well, I think, look, I mean, I've been fortunate in my career. I had role models who were urologists and, the top people in prostate cancer. And so I do agree with you that, as you may know, like to get into medical school, you have to have somewhat decent quantitative skills. But, that's why I like to continue to be in academics because, it's kind of like you use it or you lose it, right? And so my collaborations with biostatisticians, they teach me a lot, and it makes you have to think about things. Whereas again, I'm not trying to undervalue if you're just in clinical practice where you're doing a lot of good by seeing a large volume of patients, but you don't have time to to kind of investigate or try to discover things, right? I see a virtual hand raise from our nice room of
sorry. Can I just jump in really quick? Because I just got a question in the chat as well earlier. I think you sort of answered this before, but they just asked, what's the best age to start prostate cancer screening if you don't have a history of prostate issues in your family?
Of course. So let me first start by saying, I mentioned genetics, right? But just to highlight the role of a family history, okay? So if you looked at men diagnosed with metastatic prostate cancer, right? And a lot of these men still had PSA screening, but when we look at how many of these men had a mutation that was passed on from father to son or from mother to son, okay? It's 11% in metastatic prostate cancer. For localized prostate cancer, that is the majority of prostate cancers that are diagnosed in the US. I would say over 85%. The likelihood of a inheritable mutation is less than 2%. Okay. And so a lot of people, for example, may know about Angelina Jolie and how she tested for the BRCA gene. She had the BRCA gene, and therefore she underwent what we call prophylactic mastectomies, or she wasn't diagnosed with breast cancer, but because she had that gene, she went ahead and had bilateral mastectomies. Okay. And so the penetrance or the likelihood you're going to develop prostate cancer just because you have a particular gene is not as high as it is for BRCA positive breast cancer. Okay. And so I'm just trying to tell you that most prostate cancers we see, there is not a family history. Okay. And so I'm not so sure that, unless your father was diagnosed with a highly aggressive prostate cancer less than the age of 50, 65, or even 60, right? Then I'm not sure that I would advocate for, every year getting a PSA for a man in his 40s, right? I talked about getting one-time PSA or getting it every 3 or 4 years in your 40s, and then basing, if it's less than 10%, then you probably don't need annual PSA testing. You could even do it every 3 or 4 years for the rest of your life. So I hope that's helpful in answering that question. Of course.
Hi. So I have one of the lady here. She's asking, what if the first test that they do is negative? How often they have to do the screening again? And then her second question, I can answer that first. And then she have another question. And then she mentioned the second question was, what if the person has no symptoms? When would be the recommended time to get it checked, or how often the person has to be rescreened again?
Of course. So the first question was, if a man has a normal PSA test, then when should it be repeated, right? So let's first define what normal versus abnormal is. So when you look at, men, regardless of age, what's considered a normal PSA? It's a value less than 4, okay? But we also know that as men get older, the prostate naturally gets bigger, as I talked about earlier. There's an increase in the number of benign cells, and so the normal PSA value is going to increase as a man gets older. For example, for men in their 40s, that normal threshold is 2.5. If it's less than 2.5, it's normal. For men in their 50s, it's 3.5. For men in their 60s, it's 4.5. For men in their 70s, it jumps to 6.5. Okay. If it's quote unquote normal, I would still repeat it, at the minimum every 2 to 3 years. Okay. You don't need to get it annually. In that European study, men were tested every 2 or 3 years. And again, that was the only randomized controlled trial. And so that's why we don't think, in the only level 1 evidence, it wasn't done annually, it was done every 2 or 3 years. Okay. Now, keep in mind too, that when a man has a PSA, it's rarely the same when you check it even 3 months apart, 6 months apart, a year or 2 years apart. There's going to be natural variation, right? And so it's kind of like the stock market, on a daily basis, it's up and down, and you want to see what the trend is over time. Okay. I think the second question was, if a man has symptoms, prostate, what should one do, or the PSA and so forth, right? So understand that, well, what are the symptoms of prostate cancer? Well, if you're getting PSA screening, you shouldn't have any symptoms, right? You're finding it so early that it hasn't left the prostate. Or there's some people that so for example, let me just give you an example. So before PSA was around in the early 1990s, how were men diagnosed with prostate cancer? Oftentimes they came to the emergency room, they had lost a lot of weight, all of a sudden they had weakness in their lower extremities, in their legs. They couldn't walk. They had muscle weakness. Okay. And that's because the prostate cancer was so widespread that it was causing spinal cord compression. All right. Or it caused a fracture. Okay. So PSA, if you are doing it correctly, moves that, shifts that diagnosis probably 10 or 15 years earlier, right? Because if you have symptoms such as these, and that's how prostate cancer presented before PSA, I mean, in those men, they weren't candidates for surgery or radiation to get a cure. The treatment at that point, again, this is before medical therapy, where you gave an injection that stopped the body's production of testosterone. Back then, men had they got a castration. That was the way to immediately stop testosterone so that it would slow down the growth of prostate cancer. So again, I'm trying to use examples of how symptoms, what are the symptoms of metastatic prostate cancer? How did prostate cancer present 30 years ago before you had PSA, right? Because, again, the non-experts that made up the U.S. Preventative Services Task Force panel, they didn't have the knowledge to understand how prostate cancer presented, prior to the advent of PSA.
Thank you so much.
It's my pleasure. It looks like we're, at the end of the hour. So I thank you for your attention. These are all fabulous questions. I'm glad it's being recorded, and hopefully we can disseminate it. And I think in doing so, I'm sure we'll save one man from prostate cancer.
Yeah, thank you so much. And just for everyone's reference, we're planning on posting the recording onto our YouTube channel. So I'm going to just post the link in the chat. And if anyone is interested in sharing this presentation, please do so. And if you want to look back on it, if you want to go over any other of those stats, that will all be there as well.
And I'll just say I would welcome any emails if anyone wants to email me directly. I know Dr. Phillips and I have communicated by email, so please don't hesitate to do that.
Thank you.
Thank you.
My pleasure. Okay. Happy Friday to you.